So to start out, I think we all know that maternal complications impact both the birthing person and the newborn. Indeed, for many years, maternal complications have been one of the most common causes of infant morbidity and mortality. And what I want to really touch on in this talk is how new studies about severe maternal morbidity in particular are allowing us to better understand the causes of maternal complications on the mother and newborn and to identify opportunities for prevention. I also just want to note that I'm going to be using the terms severe maternal morbidity and maternal mortality by convention, but for more precisely, this refers to people who are giving birth who may or may not be a mother. To disclose, I have no financial or familial relationships related to anything presented here. So really just quick outline about what I'm going to touch on during this talk. I'll give a brief overview of severe maternal morbidity, which I might refer to as SMM. I'm going to talk about the effects of SMM on birthing people and infants, and discuss the common causes of SMM, stillbirth and preterm birth in particular, and then finally discuss some of work I've contributed to on disparities in SMM, or very briefly touching on ongoing and future work. So I am an epidemiologist by training. This talk is going to launch into a lot of data. And before doing so, I think it's really important to start out by remembering that every single one of these statistics is a person, and these people have stories. And it's really been the stories of these people that have galvanized attention to the public health issue of maternal mortality and morbidity in the United States and have led to a lot of action over the past several years. And in addition to these people, every single one of these cases affects a family. And shown here are some of the surviving families of maternal mortality, as well as their organizations at the bottom. So as people are probably now well aware, unfortunately, the United States stands out among high resource countries in our rates of maternal death. And the maternal mortality rate in the US is the highest among all high resource countries. In 2018, the US started reporting a maternal mortality rate largely due to the push of attention to this issue. And you can see here it's now been released for 3 years and unfortunately has been increasing. In 2020, that was 861 people died during pregnancy or during the postpartum period, which translates to a maternal mortality ratio of about 24 per 100,000 live births. And although this is far too many people, this is a rather rare number, which has been limiting in research and quality improvement efforts. And so we often think of maternal morbidity as a continuum, which you can show here from a pyramid idea. And so because of this, there's been a lot of focus now on severe maternal morbidity, which is much more common than maternal mortality, about 100 times more common, but shares a lot of the same causes. And therefore, having research and quality improvement focused on maternal morbidity is also improving health overall and preventing maternal mortality. I would note here that this pyramid, although useful for understanding the continuum of severity, does distort the numbers. These events overall are rare, so about 1.5% of people are affected by severe maternal morbidity, and 70% of people who give birth have an uncomplicated delivery. And for those who might want to see some approximate numbers, like I mentioned, it's about 800 maternal deaths per year in the US, about 50 to 60,000 cases of severe maternal morbidity. And in total, we have almost 4 million births a year in the country. And so unfortunately, like maternal mortality, severe maternal morbidity has also been on the rise in the US over the past several years. And as I mentioned, currently it affects about 50 to 60,000 people per year, kind of depending on how you measure it and which data source. And that's about 1 to 2% of births. There's different definitions of severe maternal morbidity, but here is the CDC's definition, which is unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. However, I would note there's also increasing attention to SMM occurring during pregnancy and the postpartum period, as that's actually a pretty large proportion of those events. And so these can be a large range of events, which I'll show here. So CDC identifies maternal morbidity as if any one of these diagnoses or procedures occurred during labor and delivery. You can see these range from cardiac events to major bleeding events and procedures like hysterectomy and ventilation. And how SMM is defined varies quite a bit by country, and this is what we use here in the US for surveillance and research purposes largely. Here I'm showing the overall prevalence of each of these indicators, and the main point is just that you can see how blood transfusion really stands out. Blood transfusion is the dominant indicator of severe maternal morbidity event. About half of SMM cases, blood transfusion is the only indicator of a severe maternal morbidity. And then after that, you can see the most common ones are hysterectomy, DIC, acute renal failure, ARDS. And because of how common the blood transfusions are, and because for people who only have a blood transfusion and no other indicators, there's findings that those are less severe events than the other cases. Now the CDC and others are recommending that both this, all SMM be reported, as well as ones where we exclude people who only had a blood transfusion. And we refer to this as non-transfusion SMM. There are also, like I mentioned, there's some variations in SMM definitions. This really varies by country, study, and purpose. So in addition to that prior definition, which I'm going to talk a lot about with research and surveillance, CDC and ACOG, the American College of Obstetricians and Gynecologists, recommend a facility-level multidisciplinary review of SMM, identifying the cases with a different procedure, which is whether there was admission to the intensive care unit or if there was a transfusion of 4 or more units of blood products during pregnancy, birth, or postpartum. And just to note, we can't use this in research and surveillance because we almost never have good data on whether someone was admitted to the ICU or how much blood was transfused. But this is really useful at the hospital level. And with that, I'm going to start going over the effects of SMM on birthing people as well as children. So as I mentioned earlier, there are short and long-term effects of SMM on people who give birth. In the short term, these include increased risks of maternal mortality, prolonged birth hospitalizations, increased risks of postpartum readmissions, and postpartum psychiatric morbidities such as PTSD. In the long term, there's also increased risk of recurrence of SMM in subsequent pregnancies, as well as death and cardiovascular events beyond the postpartum period. And notably, there was a recent study out of Quebec that with 30 years of follow-up data after pregnancies, and they found a 50% higher hazard of death among people who had had an SMM in their pregnancy, showing just the long-term effects or indications of health for people over the long term who have SMM. And as I mentioned, SMM is also strongly associated with fetal and neonatal health. Here's some data out of California. And so showing that among people who have SMM at the time of birth, about 3% experience a stillbirth or a fetal death at 20 or later weeks of gestation. That's compared to about 0.5% among people who don't have SMM. 32% of people with SMM give birth preterm before 37 weeks. That's compared to 8% in people without SMM, and 10% give birth very preterm or before 32 weeks versus 1% among people without SMM. To kind of flip thinking about that, among preterm live-born infants, about 3% have a birthing parent who experienced SMM versus 0.6% among full-term infant. And of course, these preterm events have downstream effects for children's health and well-being. So to dig a little deeper, as I mentioned, SMM is strongly associated with stillbirth. This is a study using California data out of Stanford. And you can see that researchers found an association between SMM and stillbirth, and particularly looked at it across gestational age. And interestingly, there's these, you can see on the gray line, stillbirth rates, and on the bottom, the black line is live birth. There's a greater association with SMM and stillbirth actually after 29 weeks of gestation. And maternal morbidity, as I mentioned, has long been known to be a common cause of infant mortality. Here are kind of the latest data from the CDC on the causes of infant mortality. You can see there are maternal complications as similar proportions to SIDS and unintentional injuries. Maternal complications now account for 6% of infant deaths, which is the same as SIDS and injuries. SMM is also associated with increased infant hospitalization costs and length of stay. Also, some data out of a study out from Stanford using the California data found that SMM was associated with a 33% increase in the cost of infant hospitalization as well as an 18% increase in the duration of the infant's stay. And these effects were largest for non-transfusion SMM and among preterm births. So among the preterm births, a non-transfusion SMM was associated with a $13,629 increase in infant cost, which is substantial, and a 1.6-day increase in the length of stay for the infant. There's also been some more and more work looking at longer term outcomes in the infant associated with SMM. In a study out of New York City, they found among very preterm infants, so before 32 weeks, they found that SMM was associated with a 39% increased risk of death within the first 6 months of life, independent of socioeconomic and clinical factors and similar gestational ages at the time of birth. So this is a survival curve showing infant survival among the infants on the top who the parent did not have SMM and on the bottom who had SMM. And so at the end of follow-up at 6 months, 92% were alive in the no SMM group versus 89% in the group who had SMM. And so clearly, this has a major impact on people who are giving birth and infants. And so a lot of the next questions are, well, what's causing these? And what can we do to prevent these tragic events from happening? So of studies that have done really in-depth reviews about severe maternal morbidity, we've learned that obstetric hemorrhage and hypertensive disorders, followed by infections, are by far the most common underlying causes of severe maternal morbidity. In reviewing opportunities for prevention, clinician-related factors have been the most common identified factors for opportunities to prevent these events. Notably, these are largely failures to identify the progression of severity of complications, which leads to delays in diagnosis and treatment. And again, that's why the CDC and ACOG are recommending these multidisciplinary reviews at the facility level, which largely have not been implemented at hospitals. And to go back to this study about stillbirth and SMM, they also looked at the causes of the stillbirth. And what they found was that SMM incidence was highest among the stillbirths that were caused by hypertensive disorders and placental conditions. And then in another study, also out of California, where they actually reviewed SMM cases to confirm that they were true severe events, they found that 41% of those people gave birth preterm. And then this table is showing what the underlying diseases were among those cases. And you can see that hypertensive disorders and placental hemorrhage were the leading diagnoses among these SMM cases that had a dual burden of preterm birth. And specifically that there were 26% with placental hemorrhage and 35% with a hypertensive disorder. Notably, prior cesarean was exceptionally high at 63% among the placental hemorrhage SMM cases, which is largely noting how having a prior cesarean puts someone at higher risk of having placenta accreta and similar conditions during their subsequent pregnancy, which can lead to preterm birth. And so this leads me to the potential benefits of efforts to prevent SMM also on fetal and neonatal morbidities. And I'm just going to highlight a few of the initiatives of the California Maternal Quality Care Collaborative, or CMQCC. The first one being the prevention and management of hypertensive disorders. These are hospital level toolkits to help improve the quality of care related to hypertensive disorders. But clearly from the prior slides, these would also have benefits for reducing hopefully the risk of stillbirth, preterm birth, and infant morbidities. Second is the support of vaginal birth and reducing primary cesareans, which is described most recently in this paper here. And again, if we can reduce rates of primary cesareans, that really improves the health for mom and baby in the subsequent pregnancies. There's also, CMQCC works a lot on development of quality measures that are used by government and quality review agencies to measure maternity care performance. These are like the Joint Commission and Leapfrog, and these really also are being widely implemented as ways to improve hospital quality for birthing people and infants. And so now I'm going to focus on some of work I've contributed to about severe maternal morbidity in California. As probably most people here are aware, California is a large and diverse state, which is really ideal for studying maternal and infant health and rare exposures and outcomes. Of every 8 babies born in this country, 1 is born in California. It's about 450,000 births per year. And California also has had a really unique investment of public-private partnerships to leverage our data to better understand and identify opportunities to improve health for birthing people and infants. And highlighting here Stanford, CMQCC, and some of the state health agencies. And as I was kind of describing some of those studies coming out of California, and I'll be doing some more, I'm just going to describe the data set that people tend to use. And this is also widely available for people who are interested in this and to better understand what kind of the strengths and limitations are of these data. So nearly every birth receives either a live birth or a fetal death certificate. And shown here is how you can really get really detailed information out of that you cannot get anywhere else in administrative data sets, particularly birth weight, gestational age, and parity morbidity. Secondly, there are birthing patient discharge data. So these are the diagnosis and procedure codes for someone's hospitalization for birth. And shown here is that's how we identify severe maternal morbidity pretty much widely throughout the US is using these discharge billing data. And so you can look at the indicators for SMM to identify it from there. And secondly, the infant also has their own discharge billing data from their hospitalization, as well as hospitalizations throughout their first year of life and ED encounters. And through efforts of a lot of people, these have all been linked together across many years, which includes millions of births. So the strength of this, as you might guess, is largely the size. It's probably the largest population-based birth cohort in the US that has information on kind of the gestational age as well as diagnoses and procedures. Population-based, so there's really almost no risk of selection bias. We have a large diversity in the state, and there's quite a lot of detail. However, there is definitely significant underreporting and some issues with data quality. These are not collected for research purposes largely. There's no direct physiological measurements, and there's no information on outpatient encounters or medications. This is just to kind of bear in mind as I go through the results. So I'm going to talk a bit now about disparities in severe maternal morbidity. A lot of my work has been motivated by this kind of primary question of who is most affected by severe maternal morbidity and mortality and why. And in this report from the CDC, you can see a figure on the left that particularly people who are Black or American Indian, Alaska Native are experiencing the highest rates of pregnancy-related deaths. And in this report, the CDC wrote that differences in proportionate causes of death among Black and American Indian, Alaska Native women might reflect differences in access to care, quality of care, and prevalence of chronic diseases. However, especially at that time, was not really a lot of evidence or research focused on those, and that's really what we've been trying to hone in on in our research. Similar to maternal mortality or pregnancy-related death, there are also major racial ethnic disparities in severe maternal morbidity. This also comes from the CDC and multi-state data showing the odds of SMM compared to non-Hispanic white people after adjusting for socioeconomic factors and comorbidities. And similarly, you see the highest rates among Black, American Indian, Alaska Native. I also just want to acknowledge that these data and a lot of the data I'm going to show aggregate Asian and Pacific Islander, and going forward, there's lots of efforts to disaggregate these groups as there are significant differences between them. So similarly, as I'm sure people have seen before, there's similar racial ethnic disparities in preterm birth, slightly different, but still highest incidence among people who are Black, American Indian, or Alaska Native. These data are from March of Dimes for the US. And very parallel to racial ethnic disparities in infant mortality, highest rates among people who are Black, American Indian, Alaska Native. So in our initial work several years ago, we started with looking at trends in severe maternal morbidity in California across these major racial ethnic groups. And what you can see here is that from 1997 to 2014, that the incidence of SMM nearly tripled among every major racial ethnic group. And after we did actually further analysis and adjusting for sociodemographic factors and cesarean and comorbidities, and we found these disparities were attenuated, but were very persistent over time. So this relative disparity has just been very steady. And actually, the absolute disparity has gotten larger. As you can see, the lines have kind of diverged over time. And then when we aggregated this data together to kind of better investigate patient level factors related to disparities in severe maternal morbidity, highlighted just in red here, the incidence of severe maternal morbidity by racial ethnic group, which is similar to what you saw for the multi-state data. And then I just also want to draw your attention to anemia at the bottom, which at the time had not been investigated. I'd say diabetes, hypertension had gotten a lot of, and obesity, a lot of attention. But anemia affects a much larger proportion of people who are Black during pregnancy and is known to put someone at risk of a higher risk of hemorrhage and then severe maternal morbidity among people who do have a hemorrhage event, which is the leading cause of SMM. So shown here is then we did a sequential adjustment for various covariates, comorbidities, cesarean birth, and anemia. And at the top are those unadjusted odds ratios compared to people who are non-Hispanic white. And basically at the bottom are after you adjust for this whole host of factors. And what you can see is that largely the disparity persists. So it is attenuated, especially among people who are Black, American Indian, Alaska Native, but it is not fully explaining these disparities and actually had almost no effect on the disparities seen for people who are Asian and Pacific Islander. And then just to focus in back on anemia, what really struck us at this time was that when you just added anemia to these models, you saw it had a really meaningful impact on the relative increased risk of SMM among people who are Black. And anemia is itself a disparity because anemia is a treatable and preventable condition. And so this has really motivated a whole line of work on that as well. So to summarize, what's a takeaway from this about the primary question of who's affected and why, that SMM is disproportionately affecting racial, ethnic, minoritized groups. This has been persistent over time and is partially explained by individual level factors, particularly anemia for people who are Black. Further, health at the time of the birth hospitalization has a major impact on disparities in outcomes. And again, this is representing disparities in health that are preconception or during pregnancy. And so as we were also doing our work on severe maternal morbidity, something, this confounding by comorbidities really just kept coming up. So basically any kind of risk factor or differences you want to compare to groups of severe maternal morbidity, because comorbidities are so strongly associated with severe maternal morbidity, it's hard to disaggregate that from events at the time of delivery. And so here, like if you want to compare a group of people with another group of people, if they have a really different case mix, one group is much higher risk pregnancies than the other group, it makes it really hard to evaluate SMM at labor and delivery, separate from that difference in their underlying health. So we looked to comorbidity scoring systems. These are widely used in health research. Predominant is the Elixhauser score. So basically people get a score for if you have hypertension and diabetes, that sums to a score. And you can use this is used widely to compare hospitals adjusted for their case mix. But the development of these scores explicitly excluded obstetric patients. And even though it's been applied largely in obstetric patients, it's really does not fit well. There was an obstetric comorbidity score that was first developed by Brian Bateman and colleagues using Medicaid claims data, and this was a significant improvement, but still had a lot of limitations. And then there also are some other comorbidity indices that just aren't applicable to administrative data in the US. As I mentioned, we basically get ICD codes, and so it has to, anything with information on physiological measurements isn't available. So our initial study goal was to develop and validate an obstetric comorbidity scoring system that can be applied consistently across US administrative data sets. And the primary purpose was to, one, summarize risk, and to two, improve the comparisons of SMM across patient populations that have different comorbidity case mixes. Just to summarize what we did in one slide, so we used these California live births from the CMQCC data, and we developed and validated the scoring system, and then we externally validated it as well in a national commercial claims data set. We considered 27 different comorbidities based on prior literature and knowledge. We looked at SMM as well as the non-transfusion SMM, as I mentioned, as kind of a more severe form of SMM. And then I used a targeted causal inference approach that was integrated with some machine learning, and that ranked the comorbidities, adjusted them for each other to come up with the scores. And then we validated it using some discrimination and calibration measures. I know this is a lot here, but this is the main point is just these were the results, especially of our first pass. We've updated it a little bit since then. And you can see at the very top are the more severe, but generally more rare conditions that are more strongly associated with SMM, placenta accreta spectrum, pulmonary hypertension, chronic renal disease. And then they're ranked kind of in lower severity, but are often more common. So at the bottom, previous cesarean birth, older age at the time of birth, and gestational diabetes. And so basically and then on the right are the points that are assigned to these relative to each other. The higher the points, the more strongly associated it is with SMM. I'm just going to show it. And also it had good discrimination and validation overall. So as a really simple example, say you wanted to compare some patients at hospital A with hospital B and what their SMM rates were, kind of adjusting for the underlying health of the patients at the time that they came to labor and delivery. In hospital A, there's someone with no comorbidity, 0, someone with a twin pregnancy, they get a score of 20, versus in the other hospital, higher acuity patients, there's someone with pre-existing cardiac disease, a score of 31, or multiple comorbidities, hypertension plus asthma plus high BMI, and they have a score of 26. And this is a hospital example, but it can really be used for any population groups. And this has now been really widely being adapted and implemented by state perinatal quality care collaboratives and others. And then if you're interested in looking more about these scores and the risk adjustment, this is all posted here on the CMQCC's website. So at the time we're developing the score, this paper came out about challenging the use of race in the VBAC calculator. And so this largely motivated our decision to not include any race, ethnicity, or socioeconomic factors in our algorithm to avoid embedding social characteristics in risk management and decision-making, and as well to enable evaluation of disparities that are adjusted for underlying health at the time of birth. And then if you haven't read it, I just highly recommend this paper. It was a follow-up in the New England Journal of Medicine about race in clinical algorithms. So in our follow-up study, we had 2 objectives. The first was to evaluate the validity of applying this updated comorbidity scoring system across racial, ethnic, and socioeconomic groups. And then second, to determine the effect of the risk adjustment on disparities in SMM. We also slightly revised the score. We added ICD-9, ICD-10 conversions. And so to jump to the results from this, these are kind of 4 different ways of categorizing population. And the y-axis is the incidence of maternal morbidity, and then you have race, ethnicity, nativity, payment method, and educational attainment, which are all collected from the birth certificate. And the red bars show what the incidence of severe maternal morbidity is before just any standardization. These are just the observed incidences. And then in the gray is after you standardize for this very robust comorbidity score. What I really just want to draw your attention to particularly is that among racial ethnic groups, there is a lot of variation. And then both before and after this really robust adjustment, people who are white have the lowest risks of severe maternal morbidity compared to all of the other major racial ethnic groups. You do see attenuation of the risk in people who are Black and those who are Pacific Islander, but also notably that people who are Asian and Latinx, you actually see an increase in their risk with risk adjustment because on a whole, they have lower rates of comorbidities. And so when you risk adjust, it's actually masking the extent of the disparities. And that's similar for people who are foreign born, who overall in the birthing population have lower comorbidities, as well as people who have Medicaid and other government insurance. Then education, we see a clear disparity that actually doesn't seem to be affected at all by comorbidities. So I think the main takeaway from this about the question of who's most affected and why is that health inequities both during and before pregnancy strongly affect but are not fully explaining disparities in severe maternal morbidity. And so I want to switch gears for a moment from a lot of quantitative big data evidence to talking about some qualitative evidence. So at the same time, I was also working on a qualitative study to gain perspectives from people with lived experiences. And this was conducted with the March of Dimes and the Black Wellness and Prosperity Center. So our team conducted 9 focus groups and 17 key informant interviews from 2019 to 2020. And these included Black mothers with prior preterm birth, clinicians who served them, and representatives from community-based organizations in Los Angeles County. And then we performed a thematic analysis. And even though this was focused on prior preterm birth, but most of these people also experienced SMM or other morbidities during their pregnancies. So 5 themes emerged that I'm just going to walk through rather quickly, but the first was that chronic and pregnancy-related stress is very common among Black mothers. A patient shared, "I had to function through this pregnancy, even though I was going through so much and at times suffering." There was also lasting trauma from adverse pregnancy experiences. A patient shared, "I thought it was my fault that my body couldn't carry my baby." There were many comments about racism in healthcare. A nurse shared that patients believe that they will have another poor experience, which makes it difficult for them to accept advice and interventions. There was cultural incongruence in the patient care. One of the community organization representatives said that we have been around this circle because people don't want to share power and resources. And there was lots of sharing about self-education and self-advocacy among the mothers. The patient shared, "You have to advocate and educate yourself for your baby because they will try to bully you." And so from this, I think our big takeaway was that Black pregnant people experience chronic and pregnancy-related stress and have lasting trauma from adverse pregnancy experiences. These are exacerbated by racism and cultural incongruence within healthcare and social service systems. So now the last study I'm going to touch on is a growing body of work here at Stanford about obstetric health disparities among people who are sexual and or gender minority. Sexual gender minority, SGM, is a term that includes but is not limited to people who identify as lesbian, gay, transgender, or queer. Approximately 7% of people in the US are SGM, and that proportion is continually increasing. And further, more than 1/3 of people who are SGM are parents, and many of these parents are building families through pregnancy and childbirth. SGM people are known to experience substantial health disparities. These include elevated rates of hypertension, diabetes, and depression. I'm quickly showing here how a framework for thinking about how these disparities are caused by dynamic interactions between levels at the factors at the societal level, community factors, interpersonal factors, and individual factors, such as minority stress and chronic stress from being minoritized and experience discrimination. Also, just mention that in all of this work on obstetric health disparities, this group has largely been overlooked, and there's been almost nothing that has focused on the specific experiences of people who are SGM during pregnancy. So our team, led by Dr. Juno Obedin-Maliver, really sought to leverage a change in the California birth certificate that occurred in 2016. You can see here what the form now looks like. So where it used to say father, and now it says parent not giving birth, and that person can indicate whether they are the mother, the father, the parent, or other. And it used to say mother on the bottom, now it says parent giving birth, and that person can indicate mother, father, parent, or not specified. What we've done is categorize people who indicated they were a mother giving birth with a mother partner, and people who had indicated they were a father giving birth, which could include people like transgender men, as likely SGM partnerships, and have used that as a way to compare those people with people in mother-father partnerships. So here we had conducted what's like the largest and most robust analysis among birth outcomes for people who are SGM, and I'm showing here the risk ratios for various obstetrical outcomes, comparing people who are birthing mothers with mother partners compared to birthing mothers with father partners. What will stand out to you at the very top is the rate of multifetal gestation, which was 8% compared to 1.5% among people in mother-father partnerships. And then the red lines are showing these unadjusted crude rates. The blue lines are adjusted risk ratios after adjusting for sociodemographic factors, comorbidities, and then multifetal gestation for many of these. And then given this focus on the talk on severe morbidity and non-transfusion severe morbidity, to show that there are really substantial disparities experienced among this group, with severe morbidity rate of 3.5% and a non-transfusion severe morbidity rate of 1.7%, which are really very high. We also looked at some neonatal outcomes, and you can see here for preterm birth, low birth weight, low APGAR score, that there are substantial disparities, they're unadjusted. However, when we adjusted, these were not significant, and that was largely driven by the high rate of twin births among people who were mothers with mother partners. Also, just note that we did not observe any differences when we were comparing fathers giving birth with mother-father partnerships. So the takeaway from this work so far has been that birthing mothers with mother partners experience disparities of obstetrical outcomes, particularly higher risk of a postpartum hemorrhage, 9% versus 4%, and severe morbidity at 3.5% versus 1.7%. This is due in part, but not completely, to the rate of multifetal gestations. And so lastly, I'm just going to wrap up with talking about some works in progress. We're really interested in clinical opportunities to advance equity. We've been doing work on assessing the contribution of differences in labor and delivery practices to racial, ethnic, socioeconomic disparities. This work being presented at the SMFM conference, which will be in San Francisco in January for those who might want to come. And we've been doing a lot of work, like I mentioned, on developing patient-centered clinical interventions to prevent iron deficiency anemia at the time of delivery, particularly among Black people. And then some research efforts and development. Also, if you're interested in any of this and would like to collaborate, please reach out. We would love that. The first is creating and leveraging new data resources for maternal and infant health research. Been working on creating a multi-state linked administrative data set, so like California, but also several other states throughout the country. We're getting an OMOP CDM EHR network, which basically means de-identified standardized EHR data across hospital systems for pregnancy and infants. And then we've been working on acquiring Medicaid claims data to add to the existing commercial claims data here at Stanford. I'm also very interested in working on improving the quality of perinatal epidemiology and surveillance with big data. There are lots of issues with data quality in this work. And 3, particularly working on informing recommendations for antihypertensive therapy during pregnancy. As I mentioned before, this is one of the drivers for both severe maternal morbidity as well as informed morbidities. Lastly, I'll do a quick plug that I'm also doing OB-GYN grand rounds in a couple of weeks. If you want to come, it will be a completely different talk. So it will not talk about SMM or anything related to that. I'll talk about epidemiological methods and perinatal research. And with that, thank you so much for your time. It was a pleasure to speak today.
Thank you. That was wonderful. And it's already generated a lot of questions. And so I do want people to know that now that we're in this hybrid, we're still well positioned to take questions from the outside. So I'm going to start with a question from Fernando Mendoza. Can you measure immigration status of the mother? And if so, does that affect SMM?
Yeah, great question. We can know from the birth certificate what state or what country the birthing person was born in. So we have looked at nativity. I'll go back quickly to one of these. I have nativity just to show you. And yeah, there are disparities for people who are, so in panel B here, this is nativity. So a little more, about half of people are, especially among people who are Latinx or Hispanic, about half are born in the US and half are not born in the US who give birth in California. And you can see that there's not really a disparity actually too much in the crude, but when you adjust for the fact that people who are immigrants actually have better health, underlying health, it's kind of masking a disparity that exists there.
Okay. Beyond the work of CMQCC at the hospital level, do you have ideas about broader public health interventions guided by your research?
Yeah, I think a big one is, of course, policy and legislation. There's been a lot of efforts. I mentioned the families at the beginning, especially have been leading for the Momnibus bill in California, as well as some federal bills that have been enacted and pushing NIH to increase funding for all of this. I think, and there's just incredible community groups that have really been doing fantastic work throughout the country, and doing our best to partner with those to implement change.
Great. Okay. Have you found disparities in SMM for patients in rural areas of California?
That's a very good question as well. Yes, there are higher rates of SMM among people who live in rural areas. We have not particularly focused in on that here in California. There's work out of Minnesota by Kizu Kojamaniel, who has really been a leader in this and has done this nationally. If you're interested in that, I'm happy to let you know and connect with her. But yeah, it's a big issue as well.
All right. So as some people know, that yesterday at the Maternal and Child Health Research Institute fifth annual symposium, we were so fortunate. The director from the NIH of the Institute, National Institute of Minority Health and Health Disparities, was with us, and I know Stephanie got to meet with him the day before yesterday. When he presented his data yesterday, he showed maternal morbidity was higher among white women, in hospitals that predominantly serve Black patients. So there's clearly something happening at the facility level. Are you able to capture that with California data?
Yeah. Yeah, I mean, I actually missed this presentation yesterday, unfortunately, but it was likely that was data out of New York City, which I will only comment. We have certainly learned that where you are. So, for instance, in New York City, it's a very different hospital systems than we have here in California. Which I think a big takeaway is just that everything varies also throughout the country, and we really need to understand how these different policies and institutions operate. So here in California, we have done work looking at that. That was led by Mahasa Mujahid and is in the AJOG, and we did not find like that the delivery hospital had a big impact on, and our work we're doing actually now is not finding a big impact about where you deliver, but rather how you are treated in the hospital where you deliver, which is different than in New York City, where it clearly matters what hospital you go to.
Yeah, that's really interesting because one of our other speakers was a woman from I forget the exact name of the entity she was from. She was a lawyer who was a Puerto Rican woman who described in vivid detail how she was treated in a New York hospital. It was horrible. So, and I'll just make a shameless plug for MCHRI. Each of those individual presentations yesterday, including the executive director of PCORI, already mentioned the director from the NIH, as well as the chief scientific officer from the Robert Wood Johnson Foundation. All of their presentations were recorded and we will make them available. Okay. What comparisons have been done when C-section was automatic in future births versus allowing VBAC?
When C-section was what?
So what comparisons have been done when C-section was automatic in future births versus allowing VBAC?
Whether there's a trial of labor after cesarean.
Don't know.
I assume so.
Okay.
Yeah, so I mean, there's a lot of work about trial of labor after a cesarean, and there's a lot of support from CMQCC to increase safety and availability of vaginal births after cesarean, though are of course risks, particularly of uterine rupture, and so I think that's a very important ongoing area of work.
And then another question that I had, and of course people in the room we'd love to take your questions as well. I was struck when you put up the definition of SMM, the first word was unexpected. Unexpected. I'm like, well, what's expected? Is that if you have a mother with cancer or a kidney disease, or I should think all of SMM is unexpected. So I was curious about that word in there.
Yeah, I thought a lot about that, especially with like placenta accreta, where a hemorrhage is actually almost expected. And so it's not really a sentinel event, but so I mean, I think that's where you kind of lose a lot of nuance when you're using these surveillance measures and public health data. But I mean, I agree with you. I also think I like to say that not only are we trying to prevent these really severe life-threatening events, but we want people to have positive, healthy experiences at birth. And that really is our driving objective too. That yeah, no one should be experiencing any of these events during pregnancy.
All right. Well, I'll say one other thing about MCHRI, and that some people will remember a few years ago, it was actually CHRI. And when Mary Chen made our little logo, which shows the mother, Virginia from your division said, well, at least the mother's in the logo. And I said, oh, let's change the name right then. I said, I make a motion that we change our name to MCHRI. So moved, seconded, done. So we're so fortunate to have such close collaborations with our maternal fetal medicine colleagues. And it's very unusual to be a children's hospital that includes MFM, but gives us such unique opportunities for these kinds of interdisciplinary collaborations. And I'm also especially thrilled, Stephanie, that MCHRI's grants on the impact of racism and social injustice on maternal and child health, that you've been so engaged in that work. So we're really thrilled that you joined us today, and I think there'll be a lot of good future conversations and collaborations. I also want to note that Stephanie's mentor is Brian Bateman. If you haven't met Brian, he's the new chair of anesthesiology, but he is a maternal fetal obstetrical anesthesiologist with an extremely distinguished career in pharmacoepidemiology and maternal fetal medicine. So another great bridge that we can create with other departments. Let's see, did I miss any questions? Oh, I think I got all the questions, and I think with that we'll conclude grand rounds. Thank you for joining us.
Thank you so much. Okay.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.